Thanks. It's a privilege to be here, and as always, and this, I just, I always love to talk about foot injuries, foot fractures, and so we're going to talk about the two most common ones here in back-to-back. Calcaneus is really a complex injury pattern. It's never been figured out completely from 100 years ago to now. We're still challenged by a number of complications of this. It's not all that common, 2% of all fractures, but when it happens in a big way. Usually these are males, usually these are workers or falls from a height or high energy collisions. And so consequently, there's a very high frequency of other injuries, spine, lower extremity injuries, bilateral, and open in about 10% of all cases. And like this egg, once it's broken, it's real hard to put back together and make it look like a joint. So you can see that, and we'll just talk through a little bit of the bony architecture quickly. There are 3 articular facets that support the talus. The sustentaculum talus is really a key to reduction, and I find that it's the anchor point for one of the most important screws to stabilize the posterior facet. The perineal tubercle is often avulsed as part of that lateral fragment, and it's a key to kind of reductions. And then the sinus tarsi, where the vascularity to the talus and all of the good stuff is in the middle of that, and we'll talk about these a little bit more. But initial evaluation has to deal with the soft tissue. How swollen is it? How blistered is it? How can you manage a surgical case through these? And then how do we assess it and image it? It's not something you want to do in the middle of the night necessarily. But if it's open, then debriding, of course, you can do when it's first available. But imaging starts with lateral film, a Harris axial view. I look for different things, and so there's an arrow here pointing to the posterior facet that's rotated, and that's something I look at. I see that, I know it's going to be an operative case if I can put the pieces back together and if I can count them, which is up to 3. And then alignment of the hindfoot on this Harris axial. You can see also that there are often extensions into the CC joint, but strangely, this is pretty reasonably tolerated as a joint. It rarely gets significant arthritis, and we kind of look at it. We don't blow it off, but we just want to know the architecture of it. And then this. Again, this is the principal fragment or the primary fragment that, or fracture line through this that puts it into varus with it. So Bowler's angle is the one object that the Canadian Orthopedic study that is our landmark really for outcomes is important to understand. You see that on the lateral side. The Gissein's angle is my key to reduction. And then a CT scan, including semicoronal cuts, is important to get an assessment of the posterior facet. We put most attention on that because that's that's really the foundation for Roy Sanders' nominal work on really the classification system that we still use with it. Because if you can count the fragments, then that's great. But if you can put the fragments back together less than 3, then you have a reasonable chance of restoring the function of this. With it. What are the indications for treatment? The purpose of this 10-minute talk is just to talk really about open reduction, internal fixation, and really not arthrodesis and not the non-operative methods. So type 2 and type 3 patterns that have not a lot of comminution. Fracture blisters, that if we can get through those in the first 3 weeks. After 3 weeks, I find that the skin is so constricted that it's very difficult to get a reduction and not have to put a flap on that. So we want to get to it within 3 weeks, and this is a pivotal point. The challenge today was to talk about how whether we use sinus tarsi approach, minimally invasive approach, or an extensile lateral. If it's within a few weeks and everything is mobile, then you can approach sinus tarsi. But if the skin doesn't let you, the patient's conditions don't let you, then you really have to do an extensile lateral with it. Indications, we've talked about contraindications are diabetes, vascular insufficiency, smoking, open fractures for fixation, okay? We may still need to debride with these, but understand that these patients historically don't do well. And if you don't have experience, it's hard to get experience on some of the more complex fractures of this. But that said, because Roy was one of the first people that started publishing about a learning curve, this is an old paper, but I think it's important to understand that really, if you are able to do up to 50 to 75 cases, you start to master it. And then again, this is the fracture blister time. If it's clear, then it's safe to work through. If it's hemorrhagic, then it's deeper. And Giordano taught us that you need to wait on those. And if they're hemorrhagic, then if we unroof them, and I use Silvadene application while we're waiting for the skin to get wrinkles, so that when it's got wrinkles, I can close it. When I set up my operating room, I always do these, whichever the approach, in a lateral decubitus with a table that is radiolucent and a big C-arm. Don't try to do these with a little C-arm. You just can't see. And then you have to have your imaging so that you're facing it. You can look. You don't have to turn your neck every time. And then you have to do it with a tech that is your routine guy. Don't do it in the middle of the night, and ask for the person that knows how to do imaging with a C-arm. That's always a challenge. And then I do them in the daytime. All right? Actually, an 8 o'clock start time, which is pretty unusual, but it happens for us in Hopkins. And so this is an extensile lateral approach. The sural nerve is at risk. You need to kind of track that. The vascular supply, this is an angiosome. And so the very corner, I do a sharp corner because it's within the area of an angiosome that provides perfusion to that tip. But there's still a reported 10% tip reduction or apical necrosis with this. So we'll walk through this very quickly. I use a 15 blade, and I just really denude the lateral wall of all tissue, and then I use a skin hook to get this up. And then once we have it up, we can see the joint, then we put K-wires in to support it. Once we get the exposure of that, then we start looking at the lateral wall. I find that it's usually loose, and I take it off, put it in the back table under guard, so it stays on the table, and then we can see the articular surface. I start by looking at the anterior process, looking at the sustentaculum. I visualize that. When these are so depressed and you see that curved posterior facet, it is something that you can see, and then you start from the sustentaculum and you work laterally. Once I get that done, then I think about the posterior facet. I'm putting K-wires in. The number of K-wires is inversely proportional to the distance from Seattle, I think. But that's just sort of an inside a joke here with this. The porcupine look of Dr. Benershka is really trademarked with it, but it does get it done. And then you've got to reduce the varus, restoring length. That K-wire, this big Steinmann pin in the posterior facet allows me to joystick this in, and then I start putting some K-wires through the posterior process. Once you've restored length, height, and valgus, then you can plate it, all right? So that's an extensile lateral. The choice of plates, there's lots, but really looking at when you're wide open, you can put about any plate on it. The key is that it's not bulky so that you can close, and the key is that it's going to be stabilizing those fragments. I always put a fragment between, or screw between the fragments of the posterior facet, and then when we get that done, I use a Broden view to assess that. This Broden view helps you look at the posterior facet and the articular surface. Minimally invasive, I'm going to briefly touch on this. It's become quite popular, and I think that my newest trauma partner had never done an extensile lateral during his fellowship. So that's a statement. But I think you have to be able to do the extensile lateral, because when you can't reduce it, the last one I did just a few weeks ago, I could not joystick any movement in the fracture fragment, so I went to an extensile lateral before. But the key is before you start your sinus tarsi approach. Here is the look. You don't have a lot of wrinkling. You make a small incision starting at the fibula and taking it anteriorly. You can see the posterior facet, and everything you're focusing on is the posterior facet first. Restore the articular surface there, and then you can percutaneously get plates, and there are instrumentation for doing this through this now, so you don't have to use the makeshift with things. But then I tend to use a K-wire. In this case, I put the Steinmann pin in medially. It helps me control the varus, and it allows us to slide the plate in underneath this. So this is also minimally invasive. This essentially K-wires reducing this. Once you get reduction, and you can see what I have is a Steinman pin plantarly to get us into a heel height and out of varus, and then a rafting screw across the sustentaculum again, which you're seeing and you're directly visualizing, and then a stabilization with a fully threaded screws. You can do this percutaneously, and essentially you start with type 2s. You start with ones that are straightforward and work up to more difficult ones. But if I know that I'm anticipating a potential fusion, then I'm going to do an extensile lateral with this. And so there's just a quick postoperative management, layered closures, meticulous interrupted sutures, bulky cotton, drain. If you drain, pull it out fast. I really don't drain very much. I let the tourniquet down after I've closed the skin with it, and I find that you rarely have a hematoma in this. But if you leave the drain, then you're going to have drainage. It's just one of the issues. And then I leave the sutures in for 3 weeks, and then I start motion as soon as the skin is fully healed. I keep them non-weight bearing for 8 weeks, and that's just my own. My thoughts about this are operative treatment in non-laborers, non-smokers, and women have the best outcomes. We don't have a lot of those in Baltimore, so we end up having a conversation with the person. The idea is to make chicken soup, okay? And yet no surgery we do can't hurt somebody. So just think of that soft tissue, think of the choice. As you gain more experience, I think the sinus tarsi is a very useful approach. The extensile lateral is still a mainstay for the kind of fractures that we tend to see at Level 1 Trauma Center. Thank you very much.